Hello, and welcome back to The Wrinkle. In case you haven't watched before, my name is Dr. Nicole Didyk. I'm an internist geriatrician, and I work with people living with dementia and their families, as well as other seniors. Today's video, I'd like to talk about a very common symptom that is a part of people who are living with dementia. Not everybody has this symptom, but it is pretty common. You might have watched our other video that is about the A's of dementia. So the A's describe what are the sort of cardinal features of dementia or major neurocognitive disorder. And they all start with A. So it's things like amnesia or memory loss, apraxia, agnosia, aphasia. And this video is about another letter A that can really get in the way. I usually find out about it because a care partner will come in with their family member who's living with dementia and kind of complain that the person with dementia has just become a bump on a log. They're spending a lot of time on the couch. They are maybe even sleeping more than before, a lot more. So getting up, eating meals, but then going right back to bed or sitting in a lazy boy chair. This is described as being a big change from the person's previous level of activity and level of drive or interest. So that even when there are things that a person used to really enjoy doing, like going outside or bird watching, playing golf, even things like eating or cooking, there just doesn't seem to be any drive to do that. And it's very frustrating for the care partner. A lot of care partners say they kind of feel like they have to be a cruise director. So if they didn't organize a roster of activities every day, the person with dementia would spend their time kind of sitting on the couch. If it's a care partner who doesn't live with their family member, they will have a similar description whereby they'll kind of find their mom or dad just sort of sitting in a dark room. The TV's not on, there's no reading material, and that's very different than the person they knew before. They'll also sometimes find that there's delicious food that used to be the person's favorite food that's kind of sitting in the fridge and not being prepared. So family members and care partners really notice this change in drive and initiation. Usually when people come to see me, they say, well, I think they must be depressed. Let's do something about this. And we do have to distinguish this symptom from depression, but oftentimes what we're dealing with is called apathy. Apathy is another A that's frequently found in people who are living with dementia. It's considered a behavioral symptom of dementia. So it's a symptom that changes a person's behavior that is a part of the dementia or part of the major neurocognitive disorder. Apathy is actually probably the most common behavioral symptom of Alzheimer's disease. And it's very prominent as well in other types of dementia, especially frontotemporal dementia. And it can be present in vascular dementia, dementia with Lewy body, Parkinson-related dementia as well. Apathy probably occurs in about 30% of people living with dementia, and some estimates are even higher. What is apathy? Well, there are different descriptions of it, but basically it's a loss of initiation, a loss of motivation, and a change in emotional expression or emotionality. So it's described sometimes as emotional blunting. I sometimes describe it as a change in the person's drive. And you have to make sure that it's not related to some other illness, like a depression. That's probably the hardest thing to distinguish from the apathy, because a lot of the symptoms of depression can overlap with apathy. But we have to also make sure that it's just not related to some other illness. So for example, if somebody stops watching movies, which used to be something they enjoy, but it's not because of apathy, it's because their visual impairment has really progressed, well then it may not be fair to call that apathy. Why does apathy bother people? So some people would say, well, that doesn't sound too bad. The person's just kind of flat, but they're not really bothering you, right? They're just sleeping a lot. Why isn't that a challenge? Could be worse behaviors. And that's true. But imagine a person you know and care about, just the type of person that they are, the activities they enjoy, the engagement with life. When we see that change, that's very challenging to watch and very difficult. We know that when people are experiencing apathy, it can contribute to self-neglect. So because of that loss of initiation, people can even stop initiating some of the basics of managing life. So sometimes people will have changes in the frequency of bathing or changing clothes or even managing continence. And that can be very embarrassing and very challenging. And it's distressing to care partners to see apathy. It may also contribute to a higher risk of not being able to live at home anymore. So when apathy is there, as I say, it is important to distinguish it from depression. People who are depressed can also have a change in drive. Usually with depression, though, we see a lot more sadness, and we will see maybe people saying derogatory things about themselves, so feeling guilt, feeling helpless, feeling worthless, sometimes more crying and emotionality that way. So if those symptoms are present, we would want to make sure that it isn't a depression, because that would be treated differently than the apathy behavior. How do we treat apathy behavior? Well, there are two main ways of going about it. And that's kind of true of geriatrics in general, is that you'll often probably hear when we're talking about treatments that there are pharmacologic or drug-related ways of treating a challenge, and then there are non-pharmacologic ways. So ways that don't involve prescribing a pill. Let's talk about the pharmacologic ways first. Not because they're more important, but let's just get that out of the way. There's limited medication intervention for apathy. It does seem that antidepressants don't really work. So unless the apathy is because the person is having a major depression, giving an antidepressant is probably not going to be helpful. And that is a discussion that I often have in the office, is that although it seems like depression, if we carefully determine that it's not, probably trying an antidepressant is not going to work. And don't forget, there can be some risks associated with antidepressants. So there can be an increased risk of falling. Some people have stomach or other side effects related to antidepressants. So we don't really want to use it unless we feel that it very well could be part of a depression. The other medication that has been looked at more recently with some success is methylphenidate. So you might have heard of this as Ritalin or Concerta. We use it in syndromes like or conditions like attention deficit disorder. And that's actually what it is approved for. It's not approved for the treatment of apathy in people who are living with dementia, but some studies have suggested that it can improve some of the symptoms of apathy. Medication or non-pharmacologic treatments of apathy in people who are living with dementia are harder to describe because what's been studied is really a range of things. So you know how I mentioned the care partner will often say, well, I have to be the cruise director and I have to come up with a roster of activities that are just the right speed and the right timing and everything to keep the person who's living with dementia engaged. Well, that's kind of what some of the interventions that have been studied for apathy, that's kind of what they did. So there was a whole bunch of different modalities that have been looked at. So some of them are music, interactive music programs. Other ones are different types of recreation therapy that involve the right amount of stimulation and the right amount of a break. That could be helpful. It could be a reminiscence therapy. It could be a sort of a tailored activity program. It could be a snoozle-in room. We can talk about snoozle-in rooms in another video, but that's basically like sort of a sensory room. If you've ever seen one, you'll know what I'm talking about. They're kind of cool. But all of those interventions have been studied and have been shown to be of some benefit. So, and the risk is usually pretty low, although sometimes there could be a cost associated with it. So the advice that I tend to give in my office when I see someone who is experiencing apathy as a behavioral symptom of dementia is to try to develop some kind of an activity program. Some of this can be done in the community based on what your community is like and what the resources are like, but most people have sort of a blend of community resources and private resources to develop kind of an activity calendar and then be able to stave off some of the boredom and some of the apathy that can happen. So I hope that that's been helpful. Apathy is definitely something that we do a lot of education about in the office because it's something that many people haven't really considered as a possible symptom of dementia. But when it occurs, it can be very challenging, and it can be helpful sometimes for us to talk about strategies that could be useful. I'd love to hear your experience with apathy and what you found was helpful to push through that as a symptom. Oftentimes we find the symptoms of dementia, the behavioral symptoms pass with time. So if something is a challenge this month, it may be that in 6 months it's not anymore. So oftentimes just allowing time to pass, the symptom will kind of progress anyway and possibly go away. But there are definitely some things that we can do to treat apathy in the meantime. So please share your experience. And thanks so much for watching. I'll see you next time on The Wrinkle.